Yeah, thank you very much, Atina. You nicely set the scene for this debate, and I will try to convince the 47% of you who feel that OCT is not yet ready for clinical routine. I do think that this is the case. That's why I was very happy to take over this role. So I would briefly like to remind you of the excellent resolution OCT can yield. You see a table here showing the various devices, time domain and spectral domain OCT, and the resolution with a modern spectral domain OCT device is now as good as 4, 5, 6 micrometers or microns, which means 2 or even 3 orders of magnitude better than the resolution of MRI. So please keep this in mind when you consider the data I will present to you in the next couple of minutes. The other aspect is an advantage over MRI is that the technical setup for measuring the patient is very easy, very swift. Within a few minutes, you can non-invasively, without dilation of the pupils, acquire these very brilliant images Athena has shown to you in her previous talk. And the other important aspect is that with the advent of the high-resolution spectral domain machines, we can collect information about various cell types of the retina, not only the retinal nerve fiber layer and the ganglion cell layer, as was mentioned earlier, but also, for example, the inner nuclear layer and astrocytes in the retina, Müller cells, which are particularly interesting, for example, in the context of neuromyelitis optica. You've heard of the two mostly used clinical scan protocols for the macular volume and the retinal nerve fiber layer here around the optic nerve. These are the two parameters you should bear in mind when you read papers on OCT or when you discuss this with your patients, because this at the moment probably yields the best or the most relevant clinical information. We can now perform segmentation. You have heard that. There are various techniques to do so, fully automated, manually corrected, and so on. This is something maybe more for science, but just to remind you of the architecture of the retina, what interests us most from a clinical perspective are the two upper layers here, the retinal nerve fiber layer and the ganglion cell layer. Again, the retinal nerve fiber layer are the axons of the retinal ganglion cells that converge and form the optic nerve and link the eye with the brain. Now, when it comes to the perspective of the patient with regards to OCT, Atina has nicely laid out the damage to the retina that occurs in MS eyes without optic neuritis and also with optic neuritis. But what counts for a patient in the end is not a structure or damage measurable with OCT or MRI or with any other technique, but what counts for the patient is function, is visual function, color vision, contrast vision, high-low contrast, and so on. So this seminal work from Canada and the US 10 years back by Fiona Costello has very nicely shown that a certain amount of retinal damage transforms into measurable functional impairment of vision in patients. And I have to touch upon this a bit more in detail. You see here plotted the retinal nerve fiber layer thickness in microns in patients with the first optic neuritis. And here on the y-axis, in decibels, the visual field. And you can see here, and these are individual values from individual patients, you can see here that across a broad range of RNFL values from 120 down to roughly 75 or 80 microns, the visual field seems pretty stable. But when a certain threshold of retinal damage is passed or is exceeded, and this is, in this work it was 75 microns, you see that the visual field becomes very poor. What does this mean? That our visual system has the ability to compensate for structural damage to a certain extent, and there may be individual compensatory mechanisms across patients, driven by their biology and disease severity and so on. But when a certain threshold of structural damage is exceeded, this becomes detectable and the patient notices severe visual impairment. And this is important also when it comes to OCT to monitor patients and also for clinical trials. Another argument to use OCT is the fact that, as all of you know, that T2-weighted MRI, which we use in clinical routine to diagnose and monitor our patients, is highly sensitive to any kind of tissue alteration, be it edema, demyelination, gliosis, axonal damage, and whatever, as shown here with an exemplary T2 periventricular lesion. But the specificity and the relevance to a clinical disease activity is very poor, as all of you know. And this may be one of the causes why we then may end up with a high number of false MS diagnoses, as was nicely shown in this survey from the United States and Canada a few years back that demonstrated that a considerable number of patients that had an MS diagnosis turned out to have something else, NMO, small vessel disease, Suzak syndrome, or whatever, or even just migraine. This again underscores the necessity to develop better outcome tools. To show that the OCT data that have been collected in the past 10 years are very consistent, I brought this slide. This shows, this is a meta-analysis again from the work by Axel Petzold that was mentioned earlier, that across countries and cohorts, there's a high consistency and robustness of the data showing damage to the retinal nerve fiber layer in eyes with optic neuritis, roughly in the range of 20 to 30 micrometers. And something similar applies, and this is from a pathophysiological standpoint, perhaps more interesting to eyes without optic neuritis. You see the order of magnitude is a little smaller here. It's roughly in the range of maybe between 5 and 15 microns. But this cartoon clearly shows that also MS eyes without prior optic neuritis show thinning of the retinal nerve fiber layer. And this could probably reflect the underlying progressive neurodegeneration which we see in brain atrophy measurements, but which we also see in retinal thinning. This is again to show that also in patients with established multiple sclerosis, damage to the retina has functional consequences, has functional implications. This is nicely shown here. You see, I would like to draw your attention to the upper part of this panel. Here, the ganglion cell layer thickness is plotted against the visual quality of life. The visual quality of life is measurable with certain questionnaires. For example, the National Eye Institute Visual Function 25 questionnaire developed for the assessment of patients with diabetic retinopathy, but also validated and then subsequently applied to patients with inflammatory eye diseases, nicely validated also in many languages. And this cartoon clearly shows that there's a correlation between thinning of the ganglion cell layer and visual quality of life in terms of the thinner or the more damage to the ganglion cell layer has occurred, the poorer the visual quality of life of the affected patients. And when you ask patients, and this is work down here from our colleagues in Hamburg, when you ask patients which bodily functions pertaining to multiple sclerosis are the most relevant to them, it's ambulation or gait, and visual function is on place number 2. And this again underscores the relevance of what we measure with OCT. When it comes to longitudinal assessments, again, this cartoon shows that the more thinning we have in a follow-up of a couple of years in this work in the retina, the poorer the visual outcome. Atina briefly mentioned the correlation or the link to MRI derived brain atrophy, and this is just to show a few examples how this can be associated on the level of an individual patient. You see, for example, here an SPMS patient with this overt brain atrophy, enlargement of the ventricles, and when it comes to the OCT images, you see a significant thinning of the entire retinal nerve fiber layer. On a group level, there are high correlations between brain atrophy and retinal atrophy. This is nice work from Peter Calabresi and his group, who monitored patients over a time course of 4 years with annually or 6 monthly OCTs and MRIs. And they could nicely show that there is a strong correlation between OCT and MRI measures of brain atrophy, in particular in patients with progressive multiple sclerosis. But please keep in mind that this does not apply to the individual patient. You cannot infer from the brain volume of a given patient to the retina or the other direction. That means the correlation on the individual level is quite poor, has not been established. So that means OCT will never become a correlate for brain atrophy. The clinical relevance now in the last part of my talk, there are 4 scenarios where OCT has a clear value. One is for differential diagnosis, the second is for therapeutic decisions, and the third is clinical studies, and the fourth is disease progression. I'll briefly touch upon these 4 points. You know that in the event of a first ever optic neuritis, the correct diagnosis of, is this in the context of multiple sclerosis, or is this in the context of NMO or Susak syndrome or other inflammatory eye conditions, may be very challenging, in particular if the MRI and the antibody status is not that convincing. And there is clear data showing that neuromyelitis optica exhibits a different damage pattern to the retina and also the retinal thinning. The retinal damage is a lot more severe in NMO as compared to MS, so this may be helpful. On an individual level, this is still a bit problematic and requires further work. But for Susak syndrome, which may be a rare differential diagnosis of multiple sclerosis, there are highly characteristic, if not to say pathognomonic features in OCT images of these patients that allow for a distinction from multiple sclerosis with a very high accuracy. Now a clinical case to illustrate how we may use OCT in clinical practice in the future. This is, I'd say, a classical history of a young woman experiencing a first ever optic neuritis, painful vision loss with a typical CSF finding of oligoclonal bands, prolonged VEP latencies, and otherwise unremarkable lab investigations. And you would probably make the diagnosis of optic neuritis and presume that given this MRI and this MRI, that this may be in the context of evolving multiple sclerosis. Now, as all of you know, it's debatable whether this patient, given that the visual acuity fully resolved after this first attack, should be treated right away, or a wait-and-see approach with a follow-up MRI clinical assessment may also be doable. Okay, so now I would like to introduce the scenario that you had the chance to perform an OCT 3 months after this initial event. Okay, and now from the images Atina showed you, you can now clearly diagnose a significant thinning of the retinal nerve fiber layer here across the entire ring scan here in black. In the red range, the individual values of this young lady compared to the normative database. So this made clear that severe structural damage emerged from this first attack of optic neuritis. Okay. Now, there's nice work from the Barcelona group showing that there's a broad range of retinal thinning that may occur following an optic neuritis event. You see there are some patients, and these graphs plot over a time of 6 months the thinning of the various retinal layers, in particular the ganglion cell layer. And you see there are some patients over here with mild optic neuritis. They lose very little tissue, but here on the right, severe optic neuritis, there is significant tissue loss, in particular of the ganglion cell layer, and this occurs presumably in the very first days or weeks after the event and not within months. You see from the curve here, this is 1 month, that most of the damage has been established until 6 to 8 weeks. So what does this mean? This is to me a scenario, and at the moment I do not have good prospective data to back my hypotheses, but from retrospective data, there is, I think, quite convincing evidence that the earlier the treatment of the optic neuritis, the better the outcome, also in terms of preservation of retinal tissue. This work from Japan shows, in the context of NMO optic neuritis, that the earlier you treat with steroids, the better the visual outcome, but also the less severe the structural retinal thinning. The same applies here. This is work again showing that when you add plasmapheresis or plasma exchange to steroids in the scenario of optic neuritis, treatment refractory, you could also help preserve retinal tissue. That means I think that time is retina, maybe not as is the case in stroke, within seconds, minutes, or maybe a few hours, but time is retina. That means we are speaking about time frames of days to maybe a few weeks. That means a wait-and-see approach, to my mind, after an acute event of severe optic neuritis, I think is not applicable to, let's say, future management of our patients. Okay, To come to the end, I just briefly want to touch that also in clinical trials, OCT has been used multiple times with, let's say, good outcomes and showing a good clinical validity. And now, for clinical management, this work, I think, is somewhat seminal, although it was retrospective in nature. This is from the IMS Visual Database, the International Multiple Sclerosis Visual System Consortium, that has collected roughly 900 patients in a database. And this was a very simple approach. The only inclusion criterion was a diagnosis of multiple sclerosis, whatever disease stage and disease course, an OCT once at a given time point during the course of the disease, and a clinical follow-up with EDSS subsequent to the OCT for up to 5 years. And the key message here was that when we assess only eyes without optic neuritis, and this is important because Atina mentioned that optic neuritis events may confound the results of OCT measurements with regards to disability progression. Roughly less than 1/3 of patients had progressed during a time frame of up to 5 years from OCT. And patients who had OCT values, RNFL values, below certain thresholds, you can read it here, had a significantly increased risk of disability progression in the next 5 years, which to my mind, again, this is retrospective, but an impressive sample size clearly shows that there is clinical value in terms of disease prediction or disability progression prediction with OCT. The same may apply to patients with early disease stage. This is nice work from Munich in patients with early multiple sclerosis who started on an immunomodulatory therapy. And they could clearly show that patients who had a NIDA status here, and NIDA was mentioned previously, they were able to reduce their INL thickness over time. The internuclear layer is considered a kind of, immunological inflammatory battlefield where, this has been shown by Ari Green, where inflammatory cells show up and where inflammation leads to a swelling of this layer. So this went down over the course of the disease with successful immunotherapy. And this is the last slide from our group. We just submitted this, showing that in patients with clinically isolated syndrome, 92 patients with a median follow-up of roughly 2 years, that when you compare for the ganglion cell layer, the lowest versus the highest tertile, that patients with the lowest tertile had a up to 4-fold increased risk of failing NIDA-3 status within the next 2 years, and the same applies to conversion to McDonald MS and to clinically definite MS. That means also in the scenario of clinically isolated syndrome, ganglion cell layer measures at disease onset seem to be predictive of the further disease course, which I think is highly relevant for a clinical scenario. To come to the end, it has been clear that at a certain stage, structural damage to the retina, which we can detect by OCT, transforms into functional vision impairment. OCT is, in contrast to magnetic resonance imaging, is easily applicable and non-invasive and can yield clinically relevant information. And recent studies show that OCT may be a useful marker to monitor patients with acute optic neuritis and also to make treatment decisions. And I also believe that for disease prediction and also measuring disability progression, OCT can be a very useful tool in the future, and this is why my answer is yes. And I would like to invite all of you to Berlin next year. You may know that ACTRIMS 2018 will be in Berlin, so I will be very pleased to see all of you there next year. Thank you.